Okay, hello everyone. I'm going to give the lecture of top concept of transfemoral prosthetic. The topic will be the socket check and alignment. So in this topic, it's going to support LLO number 3, where basically the transfemoral prosthetic, which relation to the socket fit, comfort, and also functional outcome. So specific learning outcome for this topic would be at the end of this lecture, you'll be able to understand the TF socket check procedure before you do an alignment and how to perform proper transfemoral prosthetic alignment, which include bench, alignment, static, and dynamic. So the outline of today's lecture will be divided into four. Is a socket test, TFP bench alignment, static alignment, and also dynamic alignment. So for the socket test or socket checks, so the first of all, after you have the socket is ready, so you have completed the fabrication and you smooth up everything, the edge, trim line, and it is already like a fittable. And the patient is coming to you guys, and you should the first procedure to check the socket test. So you may ask patient to stand between the parallel bar or the handrails. It depends on availability, and help to don the socket in. Yeah, sometimes because the patient, especially if the patient is primary, you need to help to don the socket into the stump correctly. So you need to make sure two things. So at the medial anterior corner, you need to make sure that the channel of adductor longus in the correct position. Otherwise, it's going to give a pain on the patient. And then let the patient stand upright at the proper height. So you need to adjust the level of the jig alignment when you do fitting. So area to checks. So first of all, so the adductor longus tendon at the anterior medial channel corner location. So it is very important to check because it often create the pain if you don't incorrectly. So ischial tuberosity. So you make sure that if you put the QL, you check it on the seat, and then you check on the containment if you fit with the IC. So check the walls. Of course, it's going to be four walls for the quadrilateral socket, and then check the proximal brim contour if for the IC socket. Check the volume, make sure there is no gap. Socket diameter, MLAP, distal end of the socket. Socket angulation, trim lines, check the contour, no rough edges, and then make sure that there is no pinching at the trim line, and then check the comfort by asking the patient to rate the comfort from 0 to 100. So how the patient rates for the comfort level, and check the color of the skin uh, of the stump, especially before donning and doffing. Make sure that there is no the problem created by the socket fit from you. So what is the alignment? Alignment, you know the alignment since the transtibial prosthetics, right? So it is actually in prosthetic. The alignment is relationship between the socket, knee joint, shank, and also the foot. So the bench alignment, you configure all the socket, knee joint, and sang and foot perform on the bench in optimum position. So the application of predetermined position and angulation according to goals, and of course it's before the patient fitting. So the things that you need to understand is regarding the socket before you do the bench alignment. So prosthesis length, so you may measure it from two ways, GT to the floor or IT to the floor. So I prefer for you guys to measure both. And the knee center height approximated from the sun side. So a medial tibial plateau to the floor. So to make sure that where the location of the knee axis. So shoe size and height as well, don't forget. And correct the heel height and socket in correct adduction angle and the correct flexion angle according to the patient and condition. So for the socket, is consider all three planes and relationship between foot, knee, and socket should be in good position. So for example, from the sagittal, so you need to give an initial socket flexion. So 5 degrees for the long stump and then less than 15 degrees for the short stump. So the range for the medium stump could lies on 5 to 15 degrees. And then if the patient has the flexion contracture, there are actually two ways to follow. First is follow the contracture or the contracture angle 5 added 5 degrees. So that the idea is to pre-stretch the gluteus maximus so that can be able to voluntary control, especially for the knee stability during loading response. For the socket adduction, the should follow the stump angle, but however, it can be more than or equal to 8 degree for the medium to long line, long stump, it depends, or about 0 degree for the short stump, or even some of the very short stump has an abduction angle. So you need to understand that, however, you need to make sure that the angulation could be remain in adduction position to prevent, to help for the pelvic stability. However, when you do have this angle according to your goal, the IT seat here, it has to be in horizontal. And then the IT containment should also be relatively in correct angulation if you provide an SGL containment. But to make it easy, if you do rectification, to make sure your angulation is adequate or according to your goals, so just see the IT seat. When the IT seat horizontal, you may check from the jig alignment and check the angulation. If it's adduction angle, then you may see the stump or the positive cast in adduction position when the IT seat is in horizontal, or opposite when the IT seat horizontal but the positive cast in ABD. So you need to to revise the angulation of the positive mold according to the goal. So here how to do a bench alignment. If you're looking at the coronal view, I think I have told you earlier. So the midpoint of the quadrilateral is not a 50% from the medial and lateral. However, it has to be the midpoint of the quadrilateral socket will be determined by 40% from the medial and 60% from the lateral. So it depends which measurement that you are taking. For example, medial lateral 10 centimeter. So the midpoint will be 4 centimeter from the middle, 6 centimeter from the lateral. So that's going to be the midpoint. So those midpoint has to be fall in the mid of the knee axis, mid of the shanks, and the mid of the heel. So from sagittal view, for example, in this case, is initial flexion angle is 5 degree. You're gonna see that the alignment line when the seat is horizontal. So you may see the seat is horizontal from the coronal and also from the sagittal. So meaning that you have properly set the alignment from the beginning, from the casting rectification. Now it's doing a bench alignment. So after you get this socket initial flexion where the fulcrum will be on the jack greater trochanter, so the TKA line, trochanteric knee and ankle line, will be lies anterior from the knee axis. So the alignment line, where it is going to be the flexion line, is going to be fall down anteriorly from the knee axis, approximately 10 millimeter, or it depends on the component, the knee component that you are using it. It can be 10 or up to 15 millimeter. From the transverse bench alignment, so the knee joint should be compensate for the internal rotation of the thigh during flexion. So when it's flexion, the thigh will be internally rotate and it's going to be a follow the anatomy. So you need to make a little bit of knee joint externally rotates of the knee axis, and you're gonna looking at the foot going to be the toe out 5 to 10 degrees externally rotated as well. So after you complete and you satisfied with the bench alignment and move on to the TF static alignment. The goals of the static alignment to check the socket fit, height of the prosthesis, adjust the bench alignment if it's necessary, and check the suspension. And it is performed while the patient is standing upright, or we call it in a static position. So before you do fitting with the prosthesis, the procedure need to be taken. The first one is the observe patient walking with their previous prosthesis, especially if the patient is a canary patient, and compare your prescription with the current prosthesis that you have, and review the information in your chart and examine the stump carefully before you donning. Make sure that there is no problem before you don. So to make sure that your socket, to evaluate your socket doesn't create any another problem. So during fitting, let's patient don the prosthesis. You could help if the patient needed. Check adductor long tendon in the correct position. Check to make sure the IT is on the seat. You may go to the side of the patient and ask the patient to flex their trunk and to lift up the IT and put your hand in the IT. And after that, ask the patient to keep it straight again. And you're gonna feel it if there is a pressure on your finger that the IT is going to be in the proper position. But if you place your finger on the IT seat, but when the patient standing upright, you don't feel anything, it means that the IT may go somewhere. It can be to superior or to anterior. It depends on the case. As and then ask the patient to stand upright with equal weight on the both limbs and check the good support if they can hold on to the handrails, and then fit about 10 centimeter apart as to width from one leg into the other, and ensure the weight is distributed equally on the both feet, 50% and 50%. After that, if the patient already satisfied and you feel that the patient have comfort enough with this, and you can go to check the height, the weight is distributed equally 50-50, and check iliac crest, ASIS, PSIS, and observe both shoulders level, check the spine, and ask the patient, it is a very important, ask the patient how the patient feels, and check again the socket fit and adductor longus tendon, ischial tuberosity, medial wall. Make sure that there is no adductor wall or too high. Adductor wall could be implied that the medial wall too low, or too high if it's going to hit the ramus, pubic ramus if it's too high. And lateral wall, make sure that there is no big gap, which is a very often to have gap on the lateral wall, and check the overall socket volume, trim lines, distal contact, not too much pressure at the distal end, and check how does the patient feel with using your socket, and check again the stump color after it doffing. And check the alignment, which is going to imply the stability. Check whether the shank is vertical and is the foot flat in contact with the floor. Is very similar with trustibial. If the patient stand with a toe rise, the socket might not have enough flexion. If the patient stand with the heel rise, the socket may have too much flexion. It's going a little bit opposite to the trustibial one. So whenever patients don't rise, it means that it's not enough flexion, but the patient heel rise, the socket may have too much flexion. Check again stability. Are the flexion and adduction angle correct? Is the position posterior wall is horizontal from the both uh, plane, sagittal plane, and also coronal plane. You need to check the TKA line. You can use a laser or a plumb line. Check the knee stability. Check the lateral plumb line. The TKA line have to be anterior to the knee axis. Try to push the knee while the patient is supported and relaxed. Do not just move the knee joint without the permission of the patient. And also check the foot external rotation, whether it is same as a sound side or not. Check the suspension. Ask the patient to transfer the weight to the sound side and lift up the prosthetic limb, and then check is there any movement of the stump, and carefully check and make adjustment as needed. The static alignment must be correctly done first before you continue to the dynamic alignment. If the static alignment is complete, it's going to have less chance for you to do adjustment or major adjustment during the dynamic alignment or during the gait one. Next is a dynamic alignment. It's primarily involved the visual gait observation. Gait deviation must be corrected systematically. Start with the major one causing other compensation. Each correction may affect overall alignment, so need to adjust accordingly. Allow some time for the patient to adapt to your adjustment. Let them take a few passes before further adjustment. Check the foot function. Heel compression during a heel strike should be 1 to 1.5 centimeter as the patient shifts the weight forward on the foot, only applicable for such foot or any foot with the cushion's heel. And then too soft a heel will make a forward progression difficult because it is too stable. And however, if it's too hard, it will causing the knee instability. Check the rotation. At the heel strike, the foot also should be stable with a minimum rotation, and hard heel will cause the knee instability because the knee will jerking anteriorly. The GRF will be far away posterior of the knee joint, create the high knee flexion moment. This is the one that we are avoiding in transfemoral. And then no room for the hip extensor to contract may also cause foot to rotate. So we'll see that whether the hip extensor, which is the gluteus maximus, has some room to contract in your socket. If you make too tight socket, too flat at the area of the glue max, there is no chance of the glue max to contract, so it could create also the foot rotation. So during mid-stand to push off, the shank should be vertical, and then push off, it should be provide easily to roll over. Too much dorsiflexion resistance causing the difficulty to roll over and initiate the knee flexion during for the swing phase, and too little dorsiflexion resistance causing the drop off and the knee instability occur during lat stand phase because there is no anterior support. Check the toe rise at the heel strike or initial contact. Excessive toe rise at the heel strike or initial contact can be results of too little socket flexion or insufficient socket flexion. However, if too little toe rise, if you compare to the sun sign, it indicates the opposite, which is too much socket flexion. And then check again also the knee stability. The knee should be stable throughout the stand phase, especially the area of the most challenging phase, which is the loading response. So there are factors that affecting the knee stability with the prosthesis. First is the TKA line, which is have to be anterior from the knee axis about 10 to 15 millimeters. Foot and ankle function, it depends on the component that you are using it, and also the socket angle, whether the socket angle give enough stretch of the gluteus max to contract effectively, make the GRF from the posterior to anterior and create external extension moment of the knee joint so that it can be more stable. The knee stability, because of foot and ankle function, early stand phase instability, it can be caused by the heel cushion too hard if it used such foot, or plantar flexion bumper too stiff if the patient using the single axis one. It is pretty much the same as the transtibial gait deviation. If it happened at the late stance phase, it can be caused by the foot too small, dorsiflexion bumper too soft, or anterior such foot too soft. And one thing is the foot too small. And the knee stability, you can also check the hip range of motion. How can transfemoral amputee stabilize the knee joint in the early stand phase? If the patient has hip flexion contracture, so it is better for you to align in more 5 degrees so that it can be more pre-stretched the gluteus maximus so that it can effectively to maintain the knee stability. Lumbar lordosis at the late stand phase can be seen if there is the hip flexion contracture. So you have to looking at that the lumbar area. If it has a lumbar lordosis, it's most likely that it caused by the hip flexion contracture. Too much knee stability, it is difficult to the knee to be flexed, especially to initiate swing phase. So the TKA line may be further anterior of the knee axis. Recommendation is 10 to 15, but you put like 20 or 30 millimeter from anterior axis. It's going to create more external extension moment. And then this is the problem that you may see during swing phase, whether it has the medial whip or lateral whips. And then it can be caused by the knee is not aligned correctly. It can be too much externally rotate, which create a middle whip, internally rotate, which create a lateral whip. Not enough room for muscle to contract, too much pressure on the posterior brim, and too much soft tissue around the femur. attachment of the silicon belt, it is not correct. The swing face check, so you need to check the heel rise. How can the heel rise occur? How much heel rise? Not enough heel rise. Both cases linked to friction control of the knee joint, so you can adjust the friction accordingly. Or you may hear what we call as the terminal swing impact. So it sounds of the knee joint at the terminal swing. And normally there is no friction to control, or if there is the extension in, you put it too tight so that they push the impact during this terminal swing, which create the sound. So final check patience during sitting, check the trim line, check the comfort, and taking off, check the stomach, stump color, and then okay. So the final check. So the sockets showing a foot alignment must be correct. Amputee must wear prosthesis for the several minutes and take off the prosthesis and check the skin for the pressure problem, redness, stomach. Not on alignment. So far you have learned alignment procedure according to the ICRC standard. However, the one that I said earlier, each component has their own way to align. So the TKA line can be varied, not always 10 millimeter anteriorly, but it can be depends. So read the catalog first. So if you have any question, you can discuss in the ad link. So thank you very much and good luck everyone. This is the reference to be followed. Thank you everyone. If you have any question, you can discuss in the ad link. And after this, I'm going to provide you with the quiz for especially socket test and alignment. So please do it for the sake of the practice answering the question according to this topic. Okay, thank you. Bye-bye.